But I'm Ray Estacio, like Karen said, Director of Community Health at the Colorado Prevention Center, which is upstairs, which I spend every Tuesday of my life recently here. And then also do a lot of quality stuff for our ambulatory care services at Denver Health and looking at various clinical endpoints. But today, I wanted to share a few things. As part of Director of the Colorado Prevention Community Health Programs, I wanted to share some of our experiences that we had with our community outreach program using CHWs on impacting lifestyle change in cardiovascular disease risk factors in Colorado. Then also switch gears and talk about the CRISP grant that we had that did with Allie and the group in terms of how we try to overlay or in the process of overlaying text messaging to help the CBD program and the trials and tribulations in terms of developing the messages and then the obstacles and the progress of the implementation of this. So just to start, I'm going to start off for a needs assessment. So obviously cardiovascular disease is the most common cause of mortality in the U.S. and also in Colorado. And of note, risk factor control is worse among the vulnerable or disparate populations in Colorado. Specifically, when you look at Latinos, which make about 25% of Coloradans, they have a higher prevalence of obviously modifiable risk factors, but less prone to go to screening events or getting treated for it, and even more so less likely to participate in prevention programs, such as the one we have here. It was interesting to note when we did a screening program a few years ago that a third of Coloradans didn't know, haven't had their cholesterol checked over the past 5 years. So what can we do about this? So what we have, and it's funded mainly by the CDPH, the Colorado Heart Healthy Solutions program. It's led by us at the Colorado Prevention Center. It's a statewide partnership to provide barrier-free CV risk factor screening and education with a strong outreach component to the medically underserved. We're currently in 27 Colorado counties throughout the state, and this is a little bit of a map to show where we're at right now. I think we're missing a few counties in here, but it's throughout Colorado, mainly in rural and frontier Colorado. We've been lucky in this regard. We've been doing this since 2008, the current version of it. We've been most of our funding comes from the CCPD program. We found early in the game that we needed to diversify our funding, so we have a lot of foundations that help us support the program. Caring for Colorado, the Colorado Health Foundation, Anschutz Family Foundation, Elk Lamar Foundation, Center of Public Health helped with a training for our CHWs, and a HRSA grant that was obtained by one of our sites that wrote us into the grant to continue this program. So just a little bit of history of CHHS. As I mentioned, we've been doing this for a while now. Our initial version of this was 2006 and 2009. We actually got funding using CHWs to do a sort of point-of-care screening, sort of like a night health fair with some education and assessment. But I still remember the day when we were sitting upstairs. No, actually, before we even moved here, thinking, are we making a dent on cardiovascular disease in Colorado? What does screening get us? It makes us realize that there's a lot of cardiovascular risk factors untreated, and screening doesn't necessarily facilitate treatment for that or improvement in that. And so we decided in that one, I think it was 3 of us sitting in the room, we said, we need to close the circle, follow up with these patients, and give a program that's accessible to a lot of underserved, especially the rural and frontier areas, to get a handle of their risk factors and maybe do something for it. And thus, the CHHS program was born, and we got initial funding in July of 2008. We started with 5 communities, and eventually merged with another CBD screening program at Denver Health, and then actually in that first in 2010 covering 37 counties. And then with the financial crisis, the budget went down, and we nadered down to about $600,000 a year to cover this program, and down to 11 counties. But it was interesting. The partners that we worked with, a lot of them wanted to keep the program and actually self-funded themselves for a short period of time to keep the programs in their sites in their counties. So fortunately, finances improved, and we got the funding back up, and now we're back up to 27 counties in the last funding cycle. So our main strategy is focused around the community health work. This is a nice picture of some of the community health workers that we work with when we had one of the retreats here in Denver. But it's a community-based case management or navigation program located in various venues. As part of it also, we realized that these guys can't be isolated from the healthcare community. So we've attached to it a detailing program with the local clinics, community clinics where our sites were, and so we do some provider educations associated with those clinics. In the core of this, we have a outreach, screening, and referral program, which is serves as a decision support tool for our community health workers, and also is a repository for the data for the program, and which I'll go in a little bit more detail. So the unique thing about this is although it's managed centrally here in Aurora by CPC, all the stakeholders are local. So we hire CHWs at these at-risk communities in the venues and the in-reach, and because we partner with some of the clinics, are done at that local setting. And they're employed locally, a lot of them with public health sites, some community clinics, but they're also employed locally. When we identify patients at risk with elevated risk factor or a high Framingham risk, they get referred to these local providers. We also made a strong effort to try and coordinate our program with potential local programs in the area. A good example might be the Diabetes Prevention Project most recently. If we have people identified as pre-diabetic, refer them as refer the DPP program as a resource for them. This graphic here is fairly complex. It basically tells you what we do for CHHS. It's broken down in three categories: the outreach and screening, what we call community case management, which is facilitated by the community health worker, and then tracking outcomes through our OSCAR tool. It's a decision support and data repository for it. So at the outreach and screening part of it, that's where we identify risk factors for participants, which include blood pressure, lipids, BMI, and glucose. And then we also identify, collect information about their nutrition and physical activity levels, and their access to medical homes, and then counsel them on site when we get that information, which is fed by OSCAR. For those at risk here, they get involved, they get activated into the program. So this is about actually 60% of our population that we see. And the CHW helps trying to navigate them between their medical home, if they have one, or trying to facilitate them getting into a medical home through some of our partnerships that we created. Then also, more importantly, I think, try and set them up with community-based health living programs. And so they act basically as a coach for these participants in terms of helping them deal with their potential lifestyle changes associated with cardiovascular risk. And then at the end, we try and get them back to retest their risk factors and see if they improved the risk factors along with their diet and physical activity. So as I mentioned, the community health workers are the central part of this. We also have some patient navigators that are within community clinic, their main goal is doing the point-of-care measurement of risk factors. When identified, refer patients to medical clinics and healthy living programs, which include walking groups, grocery tours, diabetes management classes, nutrition programs, etc. And then also, as I mentioned, provide support. We do measure their readiness to change, and then also through motivational interviewing, try and get from them an action plan for a achievable target or goal. So I mentioned Oscar a few times, and this is kind of central to our intervention. This is it took us a while to develop this. The community health workers use it on site and fill it in. So what's loaded on here is before we contract with a site, we do a little bit of a scan of the resources in that area. And we actually load up Oscar with these resources so the CHW could have them on hand when they talk to patients. So the participants. So when they work with a participant, they use this Oscar tool to help cue them about questions they have. And as I put up this screenshot here, this one is looking at the readiness to change in terms of how ready are you to make changes to improve your health. And then we categorize what kind of things they want to work on for potential risk, whether it's smoking, improved cholesterol, hypertension, lose weight, being more adherent with seeing their health provider, increase their physical activity, or improve their nutrition. And then we're trying to get a specific action plan that they can hopefully follow and achieve, and which the community health worker can help coach them through with follow-up phone calls or visits. And so after that end of that visit, what happens is, which is kind of nice when they put all that data in during the first visit, one of the things that we really wanted is to be able to standardize the message that we send to our participants. So we created within this Oscar tool, using some of the guidelines and some of the recommendations embedded in it, algorithm to spit out some of these this information to the participant in terms of telling them what their BMI is, and then we'll have to change this because of the new global risk score, but the Framingham risk score in terms of where they lie. So if you recall, the Framingham risk score takes your risk factors, puts them in an equation, and projects a 10-year risk for CV mortality, morbidity. For this example here, this patient's in the green with a 3% risk. And then it spits out this information, which at the same time we could send to providers, if they have a provider, in terms of what findings we find. So this one specifically says, congratulations, you're low risk. 3 out of 100 people will have a heart attack or stroke in the next 10 years, similar to you. And then gives them a little bit of advice in terms of what to do in terms of follow-up. So, have we moved the needle or achieved what we were trying to achieve with this program? So we published this last year in American Journal of Public Health in a population that had follow-up visits that had their risk factors rechecked. So as you can see here, we looked at Framingham risk score, body mass index, blood pressure, and cholesterol profiles. This column over here looks at the whole population. They're all pretty significant because the numbers are so large. They're statistically significant in the right direction in terms of improving their risk factors. More important to me, since the effect here can be diluted by people with normal values, we looked at folks who had out-of-control risk factors and look at that specific risk factor for them. And here you can see a significant decrease. One of the things that impressed us most is a decrease in LDL by 18 points. That's probably associated with referral to a physician and getting medical therapy. That's the same thing with systolic blood pressure. because the lifestyle changes didn't really change all that much, but systolic blood pressure decreased by nearly 50 millimeters of mercury for that population. Again, it's probably due to participants not having primary care to start with. We found a lot of those, and then referring them to a community health clinic for further follow-up. But although we screen a ton of people, over 35,000 or 40,000 Coloradans, 60% are at risk and are currently enrolled in the program. But the biggest thing is that only 20% end up following up with us. It's still a large number of patients or participants, but it's still a rather low number. Of course, we don't know if we referred them to a community health clinic and they stayed there, so that's great, but we don't have follow-up data on those folks. But for 20% of the people, we did, it is decreased to 20% in terms of follow-up data. So one of the strategies we had then is, we work with community health workers, and so we have 18 of them or so scattered throughout the state. We're here in Aurora. There's only 5 of us actually, part of our department. So it's hard to figure out what's going on in all these places. When we were at the point where our funding was fairly low, we weren't able to help fund some of the supervisors. So what we were finding out through meetings and stuff, our CHWs, they certainly love having the body in their clinic or their institution. We're pulled in many directions at the sites to do various tasks, which was fine with us, but it kind of detracted from the focus of this risk factor reduction program. So one of the lessons learned was it was clear that we had to have their supervisor a little bit more engaged. And of course, with increased engagement, you have to also include funding. So that goes hand in hand. We've done a little bit better with that. It was also important feedback from the community health workers that we need clear goals in terms of the follow-up, and then less attention to screening new participants. All of them love screening because they like going to a center, an event, whether it's a health fair or where it's the county fair. They love going there, checking people's blood pressure, checking their risk factors, and giving them advice there on the spot about their cardiovascular risk. So as I mentioned earlier, we need to do more than just screening, and then we felt that it was really important once we identified patients that the focus, and we over-communicated this a lot, the keys over-communication, is to focus on follow-up on those patients at risk. Other things we did to help increase engagement, I do this at Denver Health, is for our providers, we have to follow blood pressure adherence and cholesterol adherence, cancers. We send them a report card, right? So there's nothing like competition and transparency and how well you're doing compared to rest. So we did the same thing here. So the things that we wanted to follow, the tool helped us create these things. So we created a report card by site in terms of follow-up calls, follow-up visits, outcome changes, compare them from one site to the other site with the intent to share successes and help problem solve with obstacles. As part of this, we do a monthly CHW meetings and quarterly meetings with their supervisors where we can share stories, share resources, and also update the group about current new things about cardiovascular risk, like the new ATP4 cholesterol guidelines, how that's totally changed things. It's now a headache for me because our tool doesn't uses LDL level as the target, whereas, as you may know, ATP4 doesn't do that anymore. Same with blood pressure control. So we have to change the tool to accommodate the new guidelines for cardiovascular risk treatment. And then lastly, we do annual retreats, which are enjoyable to everybody. They come here, actually. All the CHWs stay here overnight. We always, motivational interviewing is a skill that needs to be practiced. And so we try to refresh your motivational interviewing skills while they're here and throughout the year. And then also share potential new tools that we might have. Yes?
What is the average age of your participants, and Do you know how many of them have any children living at home?
I can't answer the latter. I have a table later on. Most of them, 70% of them are in the 35 to 60 range. I would say the high 50s was the median for it.
So they might have kids at home who look or who are shaped kind of like they are.
Yes, and so yeah, that's a great point. That's one of the things on our long list of things that we might want to do, because it's really important, especially in the Latino communities, that their home has often multiple generations living in them, and including them in the decision making in terms of what to do is really important. Because I've learned from past studies that although I'm targeting these grandmothers or grandfathers and older, they're not the breadwinners at home. So to influence change and changing what you're buying at the store, you have to also include the whole family, which includes the breadwinner too. So, but that's another project. So, but yeah, you're totally right. We haven't gone down that realm in that regard.
Estacio?
Yes.
Primary language for these groups.
So the main is Spanish and English.
So is it sort of like a 50-50 split between Spanish and English in terms of the?
You know what? I meant to look that up, but it's about 40%. No, actually, yeah, about 40%, 30%, 40% Spanish.
Okay.
So, but we have nearly about 50% Latino. But I think a third of them, a quarter of them, are Spanish-speaking only. So. Any other questions? So those are kind of strategies to try and improve the follow-up and engagement in our CHWs. So it's always never enough, right? So well, actually, here's an example of just a snippet of a report card that we show to everybody when we have these monthly meetings. So they get compared here, so you can see Clear Creek County Public Health in terms of their screening goals. How well they've done. You can see here Costilla counties had overreached and screened more patients than we anticipated. So it's always a good tool when you show the transparency in terms of your performance. It's always helpful. And it also helps them ask the questions, what are you doing in your set that we're not doing here? So that helps generate that conversation. But like I said, it's always not enough. And so a few years ago, I actually submitted an R21 to overlay text messaging into our program, see if it increased engagement. Unfortunately, as you may recall, R21s aren't much money. And so although he got a really good score, he got encouraged to reapply, at the end of the day, I'd be losing a lot of money and couldn't cover all the costs with R21. Fortunately, Chris came along. And Allie said, Jack Westfall, when he was here, said, well, you should talk about your program there and see if you can get fund it. And so I said, oh, okay, let's do that. And fortunately, Chris came along and helped fund this part of the study. So we were looking for a way to increase engagement in our population. So the CHW was fine. There's evidence in the literature that they're helpful. It's still up in the air a little bit in terms of a program that we're doing right now, if it's actually helpful. It's been helpful for hypertension control, for chronic disease management and diabetes. But we're out in the free range here, out in the community with a lot of these community health programs. So we're still kind of testing it. We think it's been helpful, but the reach of the follow-up is what's in question. So we're looking for a potential opportunity to improve that engagement, maybe connecting directly to the patient, or keep saying patient, participant, in terms of getting them more engaged in their self-care. At Denver Health, we've been playing around evaluating the role of text messaging for chronic disease management, specifically diabetes. And so in terms of control, we're using it for, I think Sheena Bull had done some STD stuff along with Denver Public Health. And so we thought I think that might be a nice solution for here. Looking at the literature, it's cost effective. potentially has a chance to improve engagement. And it's one of those technology things that has sort of that digital divide, that more disparate population more actually use the text messaging more than others. And so it may be a way to decrease the disparity in reaching some of these populations, because we thought text messaging was good. We actually did a little survey for another study at one of our community clinics at Denver Health, and we surveyed them in terms of use of text messaging and the internet. And so, yeah, 3/4 of them to 80% would use text messaging at Denver Health. And a very, very low percentage would use the website. That might have changed a little bit with smartphones, but that was back then. And so we went to see if we could do direct communication with participants using text messaging. So so our project for CHRISP is improving cardiovascular screening and management through a bidirectional personal and technological interface. So I didn't come up with that title. So I think Jack was the initial PI. Karen's with Jack's departure is taking over the PI role for this study. So our main objectives was using initially we had a qualitative methods to refine the text messaging intervention integrated with a web-based cardiovascular prevention registry. The CVD prevention registry was Jack's Just Check It. I forgot what the original registry was called, to improve participation in a statewide community cardiovascular screening and navigation program that uses community health workers. So we're going to use text messaging and then try and combine it with the CVD registry in the CHHS program. So, so you get a feel for what we're going to. So CHHS is the environment, and then we overlay the intervention in that environment. And then after some focus groups and developing messages, pilot the intervention, see if it impacts engagements and improvement in lifestyle risk factors. So here are the specific aims, basically what I just said. We use focus groups to help design the platform and intervention, develop text messaging platform containing the messages and algorithms, and develop a CV prevention registry. Then test this in 2 of our sites. So obviously it's kind of nice we already have a database in place. Take 2 counties, do the text messaging in those 2 counties and compare them to the rest of the state and see how well they do. So a lot of this work initially is Dr. Albright. She in Page, we did focus groups to help inform what the text messaging would look like. We already had a sense in terms of chronic disease management. Again, we're stepping outside the healthcare health organization environment and going into the community. So one of the things the focus of the message is really focused on process in terms of getting engaged with community health workers, getting engaged with the program. Also some messaging about blood pressure, how to prevent it, how to control it, physical activities, and then some educational reinforcement. And so here are some of the example messages we tested in these focus groups. I think we had 4 focus groups, right, Karen? And then about 3 to 10 per focus group. They were done actually in Mesa County and San Luis Valley, if I recall. It was an interesting way we did this. So they had to travel. Well, I sat in Denver Health in the evening, sending out the text messages to the focus groups while Karen Page interviewed the patient. It was actually a fun way to do it. So I could hear the phones ring over the line when I sent it to them, and then Karen queried them with certain questions in terms of how they accepted the text messaging. So here are some examples of the messages that we had for our focus groups to look at. At the end of that first focus group, it was clear things that they wanted. They wanted to know who that it's coming from. So common recognizable name of the text message. So we made sure it had CHHS, which stood for Colorado Heart Healthy Solutions, which is our program in which they were enrolled in. A bummer to me was that in looking at the literature, we thought that being interactive would be a benefit. It surprised me that they actually in the focus groups, they didn't want that interactive part of it. They didn't want to reply to the text messages. I think, and so they wanted more inspirational messaging and not so much demands in terms of what they need to do. Obviously, they wanted this message to be short and sweet. We're limited by the amount of characters we could give them, 160 characters per text. No more than one message per day. And the best times for the focus groups was in the morning between 7 and 10 a.m. And they wanted to make sure, one of the things they wanted is they wanted trusted information. So they wanted to receive factual information. So after getting that input from them, we redid our messages and set up our platform. So the way this is set up is we have an infrastructure at Denver Health. It's called PRM, Patient Relationship Management System, where we load the messages and we can schedule the outgoing messages to the population. So after getting their feedback, we actually decided, we did a pilot study with these 40 participants at 2 sites. We did 3 or 4 messages per week with a common theme each week, so 1 theme per week. And then we ran it, we actually are running, I think, 6 to 8 weeks rather than 12 weeks by the focus group interviews. And then we sent it out. And then afterwards, we did another post-pilot focus group to see what they thought of it. Because, helping design, helping craft the messages was one thing, but to actually get involved in it for a number of weeks is another. And it was, I was thrilled with these results. Some of the feedback is that they're acceptable, enjoyable. They were enthusiastic about the program. And it was one of the messages was, I think the best part of getting the text messages for me was that a seed was planted. So that's exactly what you want them to say, right? One of the things too, which was really interesting, for a lot of them, they thought it made a difference in terms of their eating and exercise activity habits. And actually shared a lot of some of the information through friends. The top messages that they thought were helpful in terms of rank frequency is healthy eating tips, active living tips, and setting goals. Oh, here's other comments. They thought the public was too short. The 3 or 4 messages per week was just right. Some of them wanted more often. And as I mentioned, they shared some of the information for them to others. Some recommendations that they had was that if we could be a little bit more flexible, a little more individualized, that would have been a tough thing to do. They wanted to replace steps with minutes for physical activities, and wanted us to be a little more, provide a little more clarity in some of the goal-setting messages. And then a lot of them, and this was last year, I believe, had mixed responses to creating a link, because we didn't actually, I think one of the things that we forgot to do is to query them about smartphones. So we wanted to see if we could put a link in their message to see so they could click on it and go to a website to gather more information. So that had a mixed response. So after getting that information, then we moved on to the larger phase of our study, is that we, for the intervention group, we wanted to focus at Conejos in Mesa County with a target of 200 participants. And our inclusion criteria is targeting new and non-engaged participants, so people who haven't had much interactions with our program. And then the control group was obviously participants that decided not to enroll to the text messaging and participants from the other CHHS sites. So, so this started almost a year ago, right? And so we figured with all that enthusiasm we got from the initial pilot response groups that it should be a piece of cake recruiting 200 participants. Although I should stop myself I'll never make that assumption again. I've had experience from clinical trials that recruitment is always the biggest obstacle. And so this is no different. despite our focus group responses for our pilot study, we tried initially recruiting through our CHWs. Uptake was pretty slow, and it was actually complicated because we lost our CHW in one of the counties of Mesa County. So what we had decided to do after we were stuck on recruitment and couldn't move the needle in terms of getting people, and we expanded to additional counties, Moffett, Route, Montrose, Ouray, San Miguel, and Archuleta. And then we also incorporated an opt-out recruitment strategy. So people meeting our criteria in terms of their data, we sent messages for a couple of weeks with an opt-out option, and we extended recruitment till last September. One of the things that I really underestimated is the number of participants who had limited text messaging plans. We didn't see that in Denver when we queried the population. So I don't know if it's a rural thing or what, but that was like a large reason why a lot of them didn't enroll. So here's a mini consort of it. And so we had sent out 219 text messaging using opt-out options. 56 opted out within 2 weeks, 163 included, which is included in analysis. And after the 2 weeks, about 28 opted out. So we have 135 still active in the program right now. So I don't have all the follow-up data for you, but I have some of the baseline characteristics. So we're still collecting data for this intervention. So the intervention, we called them enrolled if they were in the trial for at least 2 weeks. So that ends 163, and we compared them. So we didn't match them yet. So we compared them to the rest of the CHHS population. It's about 25,000 baseline data. As you can see here, a little bit more than half are females, similar for both. The age group, as I mentioned, 75% were between 35 and 64 years of age, similar to folks not enrolled in the text messaging program. 40% of our text messaging, that enrolled in text messaging were Latino, with 60% in the other groups. And a large part population of our text messaging was good in English. When we look at employment, about half were employed, similar in both groups. In terms of some of the risk factor distribution, in terms of comparing them to the rest of the CHH population, they tended to see, at least on data, look a little bit healthier. There was no comorbidity in our 163 enrollment patients versus 6.5 and 9.7% for heart disease and diabetes, respectively, for the rest of the CHHS population. Again, this is obviously a much larger number. The amount of smoking is obviously a little bit less than the CHHS population that when we looked at them. So here are some dietary comparisons. In terms of fat intake, it's a sizable amount for both populations, about 50 to 60%. About 30% in both groups did aerobic exercising 3 times a week. And the body mass index for this group is fairly similar. About 78 or so, 75% of the population were either overweight or obese. So we still have results pending. We will evaluate the following measures: participant engagement in the program, number of contacts with the CHW, and utilization of community resources. Again, if you recall, it's new participants and participants who've had a historically bad, haven't really contacted our CHW over a period of time. Right now, I think our initial calculation is about 30% of those population were a little bit more engaged, so a little bit higher than what some of the initial data that we saw. Program retention, also we're going to look at the portion of participants with at least 2 interactions within the last 2 months of the follow-up period. As I mentioned earlier, about 137 of those are still active in the program. Then we'll evaluate the following measures: the healthy behaviors that are embedded in our data collection tool. And then so obviously the biomarkers in terms of weight, BMI, changes in blood pressure, lipids, specifically LDL cholesterol from baseline. And then also as a follow-up, I think which would be really interesting to do, Karen and Paige are going to help lead more focus groups after this and see why some of the obstacles and likes and dislikes of the programs. We actually had already sent out surveys to people who opted out. We're in the process of doing focus groups and key informant interviews starting in June, again to evaluate the likes and dislikes of the program, which include frequency of messages, content of messages, and then the limitation of that technology itself. Like I said, we underestimated the role of the plan in our study. So identify mobile plans, and also since there's an uptake in smartphones, the option of utilizing smartphones in some of these focus groups. We also like to figure out predictors of adoptions at this site in terms of their age, race, ethnic group, the education level, economic status. Then finally also look, and I could probably pull this up for this talk, if the group involved enrolled in text messaging had a higher readiness to change or more activated than the other groups. Because that potentially could act as a filter to identify people that might be receptive to something like this. And that's all I have for today.